So thank you, everyone. So this talk really is based on some new evidence and guidance that's been supplied by the British Heart Rhythm Society about how we could better support theatres and our anaesthesia colleagues to deactivate defibrillators at the time of surgery. So the outline, so what I'm going to do is just touch over what we currently do here at NUH, and then give a bit of rationale for why I'm proposing we change, along with the recent evidence and support for the change. And then what I'm hoping to do is to canvass some opinions and show you the proposal for the SOP. So you may all be familiar with this guidance. This was written by Dr. Chen and I a number of years ago, and it's had different upgrades and variations. We had a drive a few years ago to remove the need for my team to attend for pacemakers, and I must say that's gone extremely well. We've had no adverse events. So this is really what I'm proposing is the next iteration of this. Why do we need to come to support patients with cardioverting defibrillators? So when we use this, what doesn't help is the varying terminology. So what I'm talking about is ICDs, CRTDs, and SICDs. Well, really, it's the risk of EMI, electromagnetic interference, interacting inappropriately with the device. So as I've just touched upon, the risk to patients with a pacemaker is very low, and we, as a trust, we manage this really conservatively. We advise to use we don't attend, and we just use short bursts of bipolar diathermy when we can. But again, people use monopolar quite widely now, and again, no adverse events. ILRs, no effect on ILRs. That's just a simple monitor. But the cohort that we're talking about here is people with ICDs, and there's a risk that if we don't deactivate their defibrillator, there's a chance that that noise can be misinterpreted by the defibrillator and deliver a shock. Delivering a defibrillation to a patient who's in a normal rhythm can actually be pro-arrhythmic, so we need to avoid this at all costs. So this is taken straight out of the current SOP that we have. And as you see down on the left side of the chart, the ICDs, it clearly says that we need the ICD therapies turning off for everyone pre-procedure whilst they're under continuous monitoring. And this is where my team come along and meet you guys often in the anaesthetic room to make the deactivation, and then meet the patient out in recovery. The thing for me is really there are so many prerequisites and caveats that we have to apply to this, that they all need turning off, where we do it, where we turn it back on. Most importantly, what happens if we can't get back to you? There's often a panic or a scramble to try and find a critical care bed with a suitable level of monitoring. So it's for these reasons really that I'm promoting that we change this, our workflow to support the service a little bit more flexibly. So what are the issues that we currently face as teams? So I can speak firsthand from the physiologist that our cardiology base is predominantly at City now. We only have a satellite outpost over at QMC. So getting over to Queen's to support cases can be a logistical nightmare. We cover lots of things at Queen's on occasion. So we may have to cover emergencies in ED, planned MRI, other surgeries. So often there can be a conflict. And actually, it's quite an inefficient use of physiologist's time, where it takes us an hour to get there on a good day. We can be over there for effectively 2 minutes to do the deactivation, then have to come back. One thing for us is that we're covering both sites for on call, so there is a risk that we can be stuck on the wrong site for where we needed. Of course, there are issues for you guys as well. Elective surgeries that need a lot of planning. If something's overlooked, we may not be there, and there's a risk that operations may get cancelled. And the need for monitored beds. This list isn't exhaustive, but these are things off the top of my head from my experience. So up until quite recently, the guidance was that all devices need to be turned off. However, in December 2021, the British Heart Rhythm Society provided us with these guidelines, and then they were echoed in Anaesthesia in 2022 about what we could maybe do to make this a lot easier, a lot more flexible. What their suggestion is actually in the top table was, if it's supra umbilicus surgery, a magnet application would be suitable. Below the umbilicus, they're saying you might not need to do anything at all. Out of ease and for clarity, I felt it would be easy that we just adopt a magnet for all patients with tachy devices. But I'd be interested in opinions. So we've got a small survey that Steve will activate at the end so we can canvass opinion on what people feel would be better. Of course, there's always the caveat that if the surgery site is within 6 inches of the device, we would still recommend formal deactivation. Likewise, for cardiac surgery and thoracic surgery, where we're dealing so close with the device, I do feel that formal deactivation with one of my team would still be warranted. So the suggestion is that we adopt the guidance which they suggest, which is the usage of a simple medical grade magnet, so the donut magnets that we have across the trust. The idea is you would still liaise with me and my team to find out what type of device you have. We would then recommend magnet usage. You would still attach them to the defibrillator in the same way, attach the magnet and then simply remove at the end. There would be no need for a post-procedure check unless you had a clinical reason for doing so. This is a process and a way of working that's used in lots of other organizations already. So it's not that much of a change nationally, but it just is for us here at NUH. Magnet application guidance, the articles that I referred to, the papers I referred to, give clear guidance on how you apply the magnet. In my experience, there are recommendations of how to apply. We will of course provide this when you contact us. In my experience, there's been no adverse effect of any misplaced magnet. I think really I did question this with manufacturers recently, and it's just about the strength of the magnetic field. But I think in practice, a magnet over has the desired effect. What I would be grateful for over time is where we station these magnets, because currently I know I've supplied them to A floor theatres at Queen's, main theatres at City, C floor theatres. I think even the ENT theatres at Queen's may now have them. So again, if people want to add in the chat, if there's anywhere that may benefit from them as well, I've got access to quite a store of these, so we could get them out. But I think the thing is, it's making sure that they're there all the time if we adopt this. So maybe a signing in and out type policy would be required. What the SOP will include is the cardiac arrest guidance. We often get asked what would happen if somebody does go into cardiac arrest and we've got a magnet. Well, the simple answer is you could just remove the magnet and the ICD would start functioning as intended. The time to detect from one of these implantable devices is 10 to 15 seconds, which is a lot quicker than it would be for you to attach, to take the external defibrillation action. So it's worth taking it off and letting it treat. But of course, you will always have the external defibrillator attached anyway, which can be used as and when required. Once the arrest situation is over, you could then reapply the magnet and continue with surgery. So it does give us a degree of flexibility that we perhaps don't currently have. So that's a bit of a whistle-stop tour.